I'd like to open the floor up for any questions for our presenters. Yes? If you could introduce yourself and say your question.
I'm Reese Myers, and I'm a hospital healthcare administrator. And I'd like to address my question to the last speaker, who was talking about the difficulty that the clinicians seem to have in just implementing these simple system changes. You know, across the developing world, there's no tradition of professional healthcare administration as a field of study. It's usually the senior doctor who becomes promoted to be the head of the system. And I think that that's a significant issue because they don't have training in health systems management and productivity improvements and the things that you were driving at. Is USAID doing anything to focus on the development of healthcare administration as a profession in the developing countries and addressing this issue of healthcare management as a lacking skill?
We'll take 3 or 4 questions and open it up. So next question. Any other questions? Okay, well, I have a question to ask Wanda. You know, one thing that's always struck me so much about the discrete choice experiments is that usually before an employer does a DCE, they really are only aware of 1 or 2 tools to affect retention. Usually it's just wages, but the DCE opens up their minds to all these different possibilities. Some of which cost money, like perhaps providing housing or paying for children's education. Some of which don't cost any money, such as putting health workers in rural areas first in line for additional training. So maybe if you could talk about some of these different options and how it really expands the flexibility for retention.
Kami Arkajavi, USAID. Question for Edward. In your first example, I think the Uganda example, you suggested that you're getting suggestions from staff on how to improve. Could you just say more about how you incentivize people actually working in the clinics to pop things into the suggestion box and see that they get implemented?
Hi, Margaret Caffrey from Liverpool School of Tropical Medicine, a partner on CapacityPlus. Really interested to hear some of these studies and some of the recommendations. Having worked on the ground with ministries of health, particularly with fairly limited capacity in terms of data analysis and even data collection, we actually have quite limited information at the moment just on basic HR, the health first workforce characteristics, and how are we going to engage governments in the labour market, in analysing labour market, collecting it first of all, then analysing and actually using it. I'd be interested to hear how you engage ministries and other government agencies on that. Thanks.
Okay, so why don't you start, Edward?
Okay. Thank you very much. So to answer to start to answer the first question, yeah, you bring up a great point. Mostly it's clinicians who are the administrators in these places, and actually in Indonesia, where I just was, it is written in the policies of most of the hospitals that these administrators have to have a medical degree, and that's just the way it is. I mean, it's partly because there is a thought, and probably correct, that doctors won't listen to anyone else except for other doctors. And it's an unfortunate thing that those doctors don't really, that there isn't the mechanisms to develop their managerial skills and their skills at other things like economics and business to be able to be good managers, to good administrators. Now, as to whether or not USAID is doing work on this, I have to admit that I don't really know. In our project, maybe Rashad would correct me if I'm wrong, but we have not received any mandate to do so. And if there's anyone in the audience who has some other comments on that, then I'll be willing to hear that.
Yeah, and I'll answer that for CapacityPlus. We've done human resource management training in several countries, mostly in Uganda, to actually train people on the skills of how do you manage a health worker, how do you hire them, how do you help, on a one-on-one basis improve their performance, how do you handle some of the problems that come at the facility level, and also with some of the faith-based organizations, particularly ACHA, which is a network of faith-based hospitals in Africa. We have helped many of them establish their first HR departments, have job descriptions for the first time. And the results of this is that they've had faster hiring times, they've had fewer lawsuits over jobs, and just increased performance. So yeah, this is something that's desperately needed. And even at the school level, most deans, through no fault of their own, have no management experience. And we've put together a series of tools to help manage schools better, just so they can train more and more highly qualified workers with their current budgets. So the lack of management in health worker training is a huge challenge. And we can do as much in-service training as we want, but in the end we have to integrate it into the pre-service education and also get management cadres recognized. You'll find in a lot of countries they don't have a cadre in a job description for a health facility manager or a health systems manager, and that's in a way one of the first steps to get these cadres, these jobs actually recognized.
So the USAID-funded Leadership Management and Governance Project has been working on the professionalization of hospital managers as a cadre. One of the focus countries would be in Ethiopia, in which a few years ago, leveraging work that was done by the Clinton Health Access Initiative, which was helped create hospital management as a separate non-clinical field. And so some of that work has been continued on by the Leadership Management and Governance Project. And then there are a number of USAID missions, so country-specific missions, that have been investing. Tanzania most recently has invested in sending some of their clinicians for hospital management training in collaboration with the Rush Institute in Chicago.
So, Wanda, did you want to address your question?
Yes, thank you. To the question regarding the DCE and the flexibility in the method, as you saw from the listing of the WHO recommendations, there are 16 different examples. However, not all of them lend themselves to a DCE, to use of a research methods. It really depends on whether they are characteristics of the job, which can be affected by the organization. For example, whether it's incentives that can be applied, the working or living conditions that can be improved. And so it's an excellent tool, especially to find some of the short to medium term factors that will motivate health workers. However, as you know, with any type of incentive, they usually have to be changed up over time. Otherwise, any incentive at first, which seemed exciting and wonderful, and in addition, then can become a more regular expected right that you receive. So you have to, then you maybe reapply a discrete choice experiment to see, what has changed over time in terms of motivation. However, at the same time, we would recommend that more of the medium to longer term strategies are looked at to then allow for what we call the rural pipeline, to allow for more health workers who, when they graduate from the training institutions, are now more of the group that would be likely to go out in rural areas. And maybe that means building training institutions outside of capital cities, so that people are coming from the rural areas around that community. They have special preference for entry into that school. There is mentoring for them. Their clinical practice in rural areas, curriculum changes more to more of a rural primary care approach versus some of the curative approach that we see in some clinical hospitals, et cetera. So there is that mix that needs to be looked at. And to the point of the data question, in order to determine which of those short, medium, or long-term interventions could be most appropriate, you really do need to have information about the health workers, about the context of the country, about the labor market. I know one example in a country, they were excited about putting together a retention strategy and were really focused on pharmacists, and as they had very, very few pharmacists out in the different regions of the country. And they thought DCE would solve their problem. When we dug just a little bit, we found out that they had one pharmacy school which had an output of about 20 new pharmacists a year. I mean, with 20 new pharmacists, there's not even enough money in the world or all the incentives you could provide to move that few people when they have the pick of the crop of urban jobs, private sector, pharmaceutical companies, et cetera. So in that case, the recommendation is really, you need to find a bit of a more long-term strategy of somehow how to scale up the number of health workers. So the data is important, and I know in some places we worry, the data is not perfect. We need more human resource information systems. That's true, but oftentimes there are a few different studies that have been implemented. There is a bit of information that even culling from that little bit really does help make better choices. And what the DCE does allow you to do is model the probability of success you may have. So before you even implement an intervention, based on the statistical modeling, you can see if we were to implement a salary increase, career promotion, housing allowance, et cetera, what would that look like? What percentage would likely accept that job post? And using costing tools like the Iris Retain software, which will be described in the roundtable, knowing the cost of the intervention you want to apply. So then you can adjust the different scenarios to meet your context and your needs.
And Cindy, did you want to address any of this?
Thanks, Wanda. Just on a comment when you were talking about the DCE and the wages. It's interesting when you look at some of the DCE results and you see the role of wage at a certain point it's very important to health workers to take up a job in the rural areas. But if you see as the level for the wages increase, the importance for wage decrease. So it's a good example of wages important, but there is a limit for that. And again, the usual policy to increase the wage doesn't really work because it's not only about wage. And just a comment about the data in the health labor market. I think when you're talking about health labor market, you increase the scope of dialogue with governments. For instance, if you talk about the employment in the health sector, you start to talk about Ministry of Finance and labor ministry, etc. So you bring a new perspective in terms of discussing health workforce, which is beyond the health sector, beyond the health ministry. And from one side, those people are very reluctant to give more money for training health workers because it has proved to be not efficient in terms of solving the health problems and the employment challenges in the health sector. And for the side is, even the health ministry, if they want to implement a recruitment retention package to attract people in rural areas, they have to look at the labor market because you cannot implement, you will not be successful, you're not likely to be successful in implementing recruitment packages if you don't have people available in the cities to go to rural areas. Or for instance, people are doing dual practice in urban areas. So the amount of money they make, the amount of compensation they have when in rural areas or in dual practice, engaged dual practice, can be usually going to be higher than the amount of bonus they get to go to rural areas. So again, I think if you look at, and if you start to talk about health labor market, you look at those aspects. That's not only about the intervention itself, but it's about the dynamics in the sector. Yep.
And I just wanted to make another brief comment about the DCE. One thing that fascinated me about the data from Uganda is one of the strongest incentives for nurses for rural retention was having adequate equipment and medicines. Well, this is just a basic requirement for good practice, and so it's sort of a win-win situation, and it suggests the policy that perhaps the government should focus maybe on fewer facilities, but making sure those facilities are properly supplied so that people have the proper equipment to do their jobs rather than demotivating them by basically putting them in empty clinics. Akika?
Thank you very much. Is this on? Mm-hmm. Good. Regarding the question about the cadres, different cadres, I think it's important that we look not only at the traditional nurses and doctors, but the whole range of competencies required to provide effective healthcare at the front line. And so at the meeting, PMAC meeting in Pattaya, one of the issues that got raised at the end was the public health specialist. That's one issue that got raised. But we had also done, in Africa, we conducted a study on under-recognized cadres, which may include lab technicians, pharmacists, supply chain managers, these the basic administrative functions that need accountants. So I think we need to look at the whole service sector and say it will vary from country to country, but where are some of these skills gap? Which gets me to another issue on governance that's come up as a major challenge. When we tried to talk about labor market surveys as a way to collect additional information, one of the big challenges we face is who is a health worker? And the definition of that cadre becomes a major challenge because, in particularly, but not only, but particularly at the mid-level, what do we mean by, I know this is maybe not acceptable term to many people, but the second-level nurses, for example, for lack of better term, I mean like the licensed practical nurses or the diploma nurses, different terms are used. What is meant by these different categories beyond the registered doctors and nurses? In many countries that we work in, this governance in this area is very poor. And so we have workers who are called midwives or may not be midwives or nurses. For example, in Japan, we don't have midwifery as a separate profession. So what's important is to have a consistent functional description of the scope of practice and what we mean by that. And we'll have to deal with this upfront because when we start to collect data on who is a health professional, we quickly run into this problem, except for the clearly registered doctors and nurses, which actually may form a small share of the total group of health professionals and other allied workers that are contributing to this. So this is something that I put forward to this group. I mean, we're focusing on discrete choice experiment, recruitment, retention, but it is an issue that's going to become a huge challenge for all of us. And not every country can have the same nurse and doctor ratios, but they may need to resort to more innovative teamwork. And then what does that mean? And that's where the innovation comes in. So thanks.
Great. Thank you. Any additional questions?
I didn't address the question that came from here about the motivation and getting ideas for changes from the frontline clinicians. And we usually help the clinics and the places where we work to identify an improvement team. So some leaders in the facility, not necessarily the most senior doctors, but other cadres who are willing to implement changes. But the first step is collecting data on the things that they want to, the important indicators of the quality of services. And once that is done, then they can identify the most significant problems, and then suggestion boxes. We don't generally use those, but they just generate ideas for changes among themselves, and then they implement them, and they look at how those indicators have changed over time. And we generally get them to post the run charts of how they're performing on whatever indicator they've decided to address. And when it's out there for the world to see, I mean, that does provide a lot of incentive to actually do something about it if it's going up or down. We try to do this in a situation where there's no blame if things are going bad. It's just, hey, I mean, we're trying, but this isn't working, so let's just try something else. We try to do it in a positive kind of way, even if the results aren't immediately great. So we just try to work on those kind of things.